Assalamu alaikum. My name is Sarah Zaman. My roll number is BP 1650200. The topic that I have been assigned is End of Life Care, chapter number 6. And the topic that I have chosen from it is aggressive symptom management and palliative sedation. Palliative sedation is the use of the medication to induce sedation to relieve the pain. Sedation is the absence of awareness. These terminally ill patients face aggressive symptoms due to the disease and therapy-related adverse effects, which can be relieved by palliative sedation. In treating the aggressive pains and symptoms, we first assess and diagnose the pain, like if it's a physical pain, it's a dyspnea, or severe nausea or vomiting. Palliative sedation is used as a last resort and it's not included in general care. Gastric cancer, also known as stomach cancer, it develops from the lining of the stomach. It has different types and subtypes with varying degree of severity. The early symptoms are heartburn, upper abdominal pain, loss of appetite. Later on, more distinguishable characteristics appear like weight loss, bloody vomiting and stools. Most common cause is H. pylori, also smoking, genetic and hereditary. Diagnosis is done on the basis of biopsy and endoscopy. End of life care cancer patients are generally end staged, terminally ill, can't be treated. Only the symptoms that they are facing could be managed to provide as much ease as possible to the patient. So the case study is DV, a 35-year-old male with gastric cancer metastasized to its esophagus with peri-aortic involvement. He is hospitalized. He was diagnosed 10 months ago. Disease progressed despite multiple chemotherapies. His most recent ones were irinotecan and Erbitux. Double lumen peripherally inserted central catheter line has been inserted. He lost 65 lbs since his diagnosis. Now he weighs 150 lbs at 6 foot tall, presents abdominal pain, severe nausea, vomiting, constipation, and a general feeling of malaise. David describes pain as 7 upon 10, burning as knife through my stomach. He uses a 50 to 75 PCA bolus doses every 24 hours. He has no other medical problems. He is referred to hospice care because he and his wife decided to stop all the chemos. He states an allergy to morphine, ondansetron, and diphenhydramine, although these allergies are not noted. He is presently receiving hydromorphone IV infusion, 2 mg per hour with 1 mg PC bolus dose Q 5 minutes, hydromorphone 4 mg per oral Q4 hour PRN for pain, fentanyl transdermal 275 mcg per hour Q3 days, ketamine 20 mg PO Q3 hour, Senna 2 tablets per oral BID, Docusate sodium 250 mg PO BID, Miralax 17 gram PO daily, Lactulose 15 ml PO PRN for constipation, Lorazepam 2 mg per oral Q4 hour PRN for nausea and vomiting, Metoclopramide 10 mg Q6 hour PRN nausea vomiting for nausea vomiting, Baclofen 10 mg Q8 hour for hiccups, and Protonix 40 mg once daily. What is your assessment for his medication regimen? We'll be seeing that. So the subject has a chief complaint of abdominal pain, severe nausea, a feeling of malaise, vomiting, and constipation. The current medication that he has been taking are these. Here the PCA stands for an analgesia, patient control analgesia. And these are also the medications. His age is 35 years. He is a male. He has a weight of 150 lbs. His height is 6 foot. No ongoing chemotherapy at the hospital as he has stopped all. Gastric cancer is metastasized to his esophagus now. The assessment is patient has end stage gastric cancer metastasized to its esophagus with severe abdominal pain, constipation, weight loss, around 65 lbs since his diagnosis. Patient is a palliative care patient now, treating the severity of his symptoms, has terminal illness with a general feeling of malaise. We assess that this patient drug regimen is unnecessarily complicated. However, it is still not helping to keep the pain in control. So multiple drugs are being used here for the same purpose, which is not helping and also decreasing the patient compliance. The more the drug, the less the patient compliance is. PCA, which is analgesia, should be given either IV or oral. If our patient is able to swallow, it's better to give him oral. else IV infusions are just enough, no need for transdermal patches. Allergy to morphine is not vague, so it's not a genuine allergy. Because as we've seen that he's given hydromorphone and he's not giving allergic symptoms, so his allergy is not vague. So we consider this allergy as not genuine. Also, the constipation is treated with multiple drugs of same class, so we can maximize the use of a strong drug in place of the multiple regimens. There is no need of giving 2 PCA bolus to the patient. One is 50 to 75 in a day and the other is 48 PCA bolus in a day. Instead, what we will do is we will give 4 mg per hour, that is 96 PCA per day. It's more effective as 4 mg per hour is going to the body and maintaining the pain and managing the pain. What is PCA? PCA is actually a patient control analgesic. What happens in it is a patient has a control button. Each time he presses it, the dose is administered into the body. It's difficult that he does it for 2 drugs, तो instead हम क्या करेंगे कि उसको एक ड्रग देंगे और उसको हम 4 mg पर आवर कर देंगे ताकि पेशेंट कंप्लायंस इंक्रीज हो, पेशेंट की कन्वीनियंस इंक्रीज हो और अच्छे इफेक्ट्स आएँ, बेटर इफेक्ट्स आएँ. Because 4 mg would be administered in a body at a time, but give better results. The next thing is when we are using IV infusions, there is no need of transdermal opioids. We will use oral opioids if the patient is stable and he is able to swallow it. But if our patient is not stable, we will give IV infusions. That should be just enough. The next thing is the patient should be switched to morphine if no real allergy exists, because hydromorphones are reserved for only genuine allergies. And also the morphine is more cheap drug and more economic for the patient. For constipation, this current regimen that he is using has 4 medications for constipation, but they're still not helpful. The 4 medications include Senna, lactulose, docusate sodium, and Miralax. Senna is a stimulant. What we will do in it is we will increase the dose from 2 tablets BID to 4 tablets BID for better results. The lactulose should be switched with sorbitol. Sorbitol concentration should be 30 to 150 ml once. Sorbitol is more economic, so we are replacing or switching it with lactulose. In between docusate sodium and Miralax, they both are stool softeners. We can skip docusate sodium because Miralax is more potent drug. Metoclopramide treats nausea and vomiting, so we can skip or exclude lorazepam. Metoclopramide treats nausea and vomiting, so we can skip lorazepam. Also, the metoclopramide treat hiccups and constipation, but with a condition that our patient should have slow bowel movement or an hypoactive bowel. So that means we can skip baclofen too. So summarizing it, we can say that we have decreased the dose of PCA from more than 100 PCA per day to 96 PCA per day. We have excluded transdermal opioids. We have increased the dose of Senna from 2 tablets BID to 4 tablets BID. We have switched lactulose with sorbitol. We have excluded docusate sodium. We have excluded lorazepam and also baclofen. Thank you.